Hi, my name is Nicole Benavides, and today we are going to talk about antithrombotic therapy after acute coronary syndrome or PCA in atrial fibrillation. We are going to talk about definition, application in medicine, pros and cons, issues applied in Ecuador, and conclusion. Definitions. Acute coronary syndrome is a term used to describe a range of conditions associated with sudden reduced blood flow to the heart. Acute coronary syndrome often causes severe chest pain or discomfort. It is a medical emergency that requires prompt diagnosis and care. The goals of treatment include improving the blood flow, treating complications, and preventing future problems. The symptoms: chest pain or discomfort, angina, pain or discomfort in one or both arms, the jaw, the neck, back, or stomach, shortness of breath or dyspnea, nausea or vomiting, sweating or diaphoresis.
Lifestyle. Now, the rupture of the plaque, the heart, which is a syndrome characterized by a reduction or occlusion of blood supply to the heart. And so we begin by revising the anatomy of the heart just quickly. So the heart consists of 4 chambers. The left ventricle here will pump blood to the rest of our body via the main big artery, the aorta. And coming off the aorta are 2 main arteries which supply the heart muscles itself. These are the right coronary artery and the left coronary artery. The left coronary artery further divides into 2 main arteries, the left anterior descending and the left circumflex artery. These arteries supply the heart muscles, the cardiomyocytes. Zooming into the area, we can see the artery here bringing blood and therefore bringing oxygen to the cardiomyocytes. Thus, it will result in a healthy cardiomyocyte. However, over time, atherosclerotic plaques can build up within these coronary arteries. And this is usually due to non-modifiable risk factors, such as aging, male sex, family history, and certain ethnicities such as being Caucasian. Now, the buildup of plaques can cause a reduction in blood flow to the area, to the cardiomyocytes, leading to poor oxygen supply. This can cause symptoms such as angina, chest pain, when people are exerting themselves. This is because when you exert yourself, the heart needs more oxygen and so needs more blood supply. But because the vessels can't meet the demand of the heart, you get angina as a result. Angina can be either stable or unstable. In unstable, you have chest pain even when you're resting. And this is, of course, a lot more serious. But, of course, the plaque can get worse, and it can even rupture, causing thrombosis. But the vessel is not totally occluded here, and this is what we can call a myocardial infarction still. The infarction of the myocardial tissue occurs distally to where that vessel supplies, and so there's ischemia proximally. This is referred to as a non-STEMI. And
Atrial fibrillation. Atrial fibrillation is an irregular and often rapid heart rate that can increase your risk of strokes, heart failure, and other heart-related complications. During the atrial fibrillation, the heart's 2 upper chambers, the atria, beat chaotically and irregularly. out of coordination with the two lower chambers, the ventricles, of the heart. Atrial fibrillation symptoms often include heart palpitations, shortness of breath, and weakness.
Your heart is a muscle that pumps blood around your body. It's made up of 4 chambers, 2 at the top called the atria, and 2 at the bottom called the ventricles. Your sinus node sends out electrical impulses. Atrial fibrillation, or AF for short, is when other areas of the atria send out electrical impulses too. These irregular impulses cause the atria to twitch. When this happens, blood isn't pumped out effectively, which could cause a blood clot to form. If this clot travels to your brain, it can lead to a stroke. When your heart isn't pumping blood properly, it can lead to symptoms such as tiredness, dizziness, or feeling faint, shortness of breath, or palpitations. How AF affects you will determine the treatment you need. Some people with AF, like Harry, only have mild symptoms or may not experience any symptoms at all. Harry noticed something might not be right when he felt his pulse was irregular and sometimes fast. Harry was at higher risk of AF because of his age and high blood pressure. Those with a heart valve problem are also at a high risk. It's important that Harry avoids further strain on his heart by getting treatment for his AF to reduce his risk of stroke or heart failure. The best course of treatment for Harry was anticoagulant medicine, called warfarin, to reduce his risk of having a stroke, followed by a cardioversion, to try and restore his normal heart rhythm. However, some people may need other treatment, such as ablation or other suitable medication. Thanks to his treatment, Harry's AF is manageable and he can return to work and exercise when he feels ready.
Antithrombotic therapy.
A blood clot can form within an artery supplying blood to the heart muscle in association with an atherosclerotic plaque. The obstruction to blood flow can result in a myocardial infarction, or a heart attack. In patients with atrial fibrillation, the most common form of cardiac arrhythmia, a clot can form as a result of the ineffectual contraction of the left atrium. If the blood clot leaves the heart and travels through the circulatory system to the brain, a stroke can occur. During blood clotting, the blood cells are held together within a mesh of fibrin. Fibrin is the end product of the blood coagulation cascade. And medicines that target individual components of this cascade have been developed to inhibit blood clotting in high-risk patients. Warfarin is one such medicine. It's an oral anticoagulant drug that's been used for around 60 years. Warfarin prevents clotting by lowering the levels of active vitamin K, a molecule essential for the maturation of a number of the blood coagulation factors. It's commonly prescribed to patients with deep vein thrombosis or pulmonary embolism, and to patients with atrial fibrillation. But unfortunately, many commonly used medicines and foods modify the effects of warfarin. Additionally, how patients metabolize warfarin varies considerably, and so its activity has to be monitored by regular blood testing. Because of these issues, many patients who should be taking warfarin do not do so, and investigators have been searching for other, more straightforward therapeutic options. Several non-vitamin K oral anticoagulants, or NOACs, have been developed over the past 15 years or so. Dabigatran is a direct thrombin inhibitor that has been approved for patients with deep vein thrombosis and pulmonary embolism, and some patients with atrial fibrillation.
Application in medicine. The incidence of AF in acute coronary syndrome patients is ranging from 10% to 15%. 5% to 10% of the patients with AF will undergo PCI. The choice of antithrombotic therapy in this population is tricky because concerns about bleeding have led to search for the best option of treatment.
Triple antithrombotic therapy is the standard of care for patients with atrial fibrillation undergoing percutaneous coronary intervention, or PCI, with stenting. Oral anticoagulation and dual antiplatelet therapy with a P2Y12 inhibitor plus aspirin are used to prevent thromboembolic events, including stroke, systemic emboli, and stent thromboses, but they are associated with a high risk of major bleeding. A potential therapeutic strategy to reduce thromboembolic events and bleeding risk is dual therapy, with the oral direct thrombin inhibitor dabigatran and a P2Y12 inhibitor without aspirin. In the multicenter randomized redual PCI trial, 2,725 patients with non-valvular atrial fibrillation who had undergone PCI with stent implantation within the previous 120 hours were randomized to receive either triple therapy with warfarin, a P2Y12 inhibitor, either clopidogrel or ticagrelor, and aspirin for 1 to 3 months, or dual therapy with dabigatran, 110 or 150 milligrams twice daily, and a P2Y12 inhibitor. The primary endpoint was time to first major or clinically relevant non-major bleeding within 14 months. The rate of major or clinically relevant non-major bleeding was 15.4% in patients receiving 110 mg dabigatran dual therapy, as compared with 26.9% in patients receiving warfarin triple therapy. Similarly, the rate of major or clinically relevant non-major bleeding was significantly lower in patients receiving 150 mg dabigatran dual therapy than in those receiving warfarin triple therapy. In the secondary endpoints, there was no significant difference in the rate of thromboembolic events or death between patients receiving 110 or 150 mg dabigatran dual therapy and those receiving warfarin triple therapy. The authors conclude that in patients with atrial fibrillation after PCI, dual therapy dabigatran and a P2Y12 inhibitor significantly reduced the risk of bleeding as compared with warfarin triple therapy, with no increase in thrombotic complications. Full trial results are available at nejm.org.
Pros and cons. Pros. The antithrombotic therapy prevents FA and acute coronary syndrome patients of developing strokes and ischemic disorders. The evaluation of the current treatment could help us to improve the way we treat patients, and they could have the best quality of life possible. Cons. The triple therapy has more risk of bleeding than the other treatment, but with the medication that is always a possibility.
On oral anticoagulants who needs dual antiplatelet therapy. And I cannot really think of a better speaker for this topic of Dominic Angiolillo from Jacksonville, University of Florida. Welcome, Dominic.
Thanks for having me.
And I would like to keep this discussion very practical for our audience. So maybe I can take advantage of your presence and try to ask you very practical advices on how to manage this therapy. First of all, if the patient needs the anticoagulant, of course, because of AFib, which anticoagulant?
Well, there are no doubts in my mind that in the absence of contraindications, they should be on a NOAC. That is for sure. The question becomes which NOAC. On a personal note, I don't have a preference towards one agent versus another. If they already came in on an agent, I keep them on the same agent. I do not switch. If for whatever reason they're a patient on a vitamin K antagonist and do not have a contraindication, then I'll switch to a NOAC. But definitely, NOAC is the treatment of choice with full stroke prevention dose in line with the guidelines.
Oh, thank you so much. So the second logical question is, how about the P2Y12 inhibitor?
Yeah, so even there, I'm pretty firm on my choice, where clopidogrel is the P2Y12 inhibitor of choice. This is very consistent with guidelines both in the United States and in Europe. We have very limited data with the newer agents, prasugrel and ticagrelor. A little bit more data with ticagrelor, particularly from one of the trials, the REDUAL trial. Those are recent analysis. I would say I would reserve the use of ticagrelor only for my patients at highest ischemic risk, but low bleeding risk. That has to be the condition, or for whatever reason, I know that the patient does not have a good response to clopidogrel.
Okay, so a NOAC first, then mostly clopidogrel with selected patients on ticagrelor. Now the maybe most difficult, at least for me, question is aspirin. For how long?
Great question. I think it's obviously the million-dollar question that we've all been dealing with. A lot of differences in terms of recommendations in the United States and in Europe. I do believe now after the Augustus trial, we do have more convincing data that a strategy of dropping aspirin as soon as possible should be considered. Now, having said that, I still believe that for some patients, a brief period of aspirin, particularly for those patients at higher ischemic risk, should be considered. But I think the overall take-home message, we should be minimizing the duration of aspirin therapy.
So thanks a lot.
Issue applied in Ecuador. According to data collected by INEC in 2014, a total of 4,430 deaths were reported from ischemic heart disease, while from heart failure, deaths reached 1,316. Arrhythmias reached 168 deaths, while those who died from cardiac arrest in the same year were 106 patients. Conclusion: AF is a common arrhythmia which can lead to serious disabilities and morbidity. In the presence of acute coronary syndrome, the serious risks posed by AF multiply. It is therefore crucial for physicians to know the proper way to manage these patients. Over the last decade, there have been robust data derived from randomized controlled trials to guide physicians' decision-making. Factors needs to be considered, including demographic characteristics like sex, age, body weight, procedures like size, location of stent, severity of disease, bleeding risk, and ischemic risk factors, the decision of triple or dual therapy, the choice and duration of antiplatelets, and the dose must take into consideration all these factors. Thanks.